Hello, this is Dr. Bhaumik, and today I'm going to present something which always like, and this is going to be the pediatric board review question part 3. Some of the questions I have taken from the pediatric review that published by American Board of Pediatrics. And here I will present 2 short cases followed by multiple choice question, and these are very much in keeping with the pediatric board examination and board recertification examination as well as USMLE 4. So let's start with the first question. An 8-year-old girl present with sore throat and a fever of 101 degree Fahrenheit for last 24 hours or so. She has otherwise been healthy except for the history of Graves' disease, and for that she has been taking medication, so under medical management. On physical examination, she has some injection of her posterior pharynx and enlargement and erythema of her tonsils. Her thyroid gland is diffusely enlarged and is non-tender. So most important study to be obtained next is, here is only one answer: thyroid function test, complete blood count with differential, sedimentation rate, throat culture, or mononucleosis test, Epstein-Barr virus serology. All right, let's look at this question. Now, confronted with a situation like that, you probably will order most of these tests. You will order thyroid test, CBC differential, sedimentation rate, throat culture. Sedimentation rate is not that important. Most of the time it's not used. Throat culture and the mono test. However, the hook of this question is right here. Patient is under medical management for Graves' disease. So when you have a fever, sore throat, and the patient is on medical management, which most likely is going to be methimazole or tapazole. Previously in this country we used to use lots of time PTU, propylthiouracil, but it's not used anymore, especially here and in the Europe. And what is the side effect of tapazole or methimazole? The most dangerous side effect of that is granulocytopenia or neutropenia with low granulocyte count, and that is really very dangerous. And that seems to occur when the patient is having sore throat with fever. And therefore we have seen that many a times that you put them on methimazole and they will be fine, but once they develop fever or sore throat with fever, and they tend to develop neutropenia. So we usually tell the family physician that, or parents, that if he or she runs fever with sore throat, need to go to the pediatrician's office or emergency rooms, urgent care, and get a blood count done. So the answer is complete blood count with differential. That is very important. So that was a little tricky question. Here is the clincher. The next is one of the case review, small case that I would say. It's a 12 months old male infant is admitted for failure to thrive. On the physical examination, his weight and height, weight and length is less than 3rd percentile. And since this patient failed to gain any weight and was admitted to the hospital, and the following lab test was done, and this is the lab you got. This patient has a serum sodium of 148 milliequivalent per liter. Normal is 135 to 145. Potassium is 4.2 milliequivalent per liter. It's normal. Chloride 108 is also normal. Bicarb 28 normal. BUN, glucose, calcium, they are all within normal range. Urine specific gravity is 1002. Is negative for protein, glucose or ketone. And there is no RBC or WBC in urine analysis. Now from this lab result, which of the following would be the most helpful test? Upper gastrointestinal endoscopy, upper gastrointestinal series with follow-through, serum prealbumin, renal ultrasound, or concomitant serum and urine osmolarity. Concomitant serum and urine osmolarity. Okay. The answer will be, you probably by now guess, is E. And why is that? This patient has hypernatremia. However, other parameters like potassium is normal. So that is speak against any adrenal problem. All other parameters, glucose and everything is okay. Another problem is here specific gravity is 1002, is a very, very diluted urine. And in the absence of glucose, protein and the ketone, it makes it even more credible because sometime when you have got other solid in the urine, that might change the specific gravity, but here is specific gravity is 1002. So we have hypernatremia and low specific gravity, and our diagnosis should be diabetes insipidus. Now, diabetes insipidus, but it does not tell you whether we are dealing with a central diabetes insipidus or nephrogenic. But remember this, that it's a male infant. So nephrogenic diabetes insipidus could be a also very valid diagnosis, because nephrogenic diabetes is X-linked recessive. Therefore, it could be a nephrogenic diabetes, but for that you have to do a little bit further test. But clinically, I mean laboratory wise and also clinically, failure to thrive is the most common presentation in the first year of life with diabetes insipidus. It is DI. Now we have another patient who is a 14-year-old girl, has a 6-month history of intermittent vomiting. She has lost weight over the period of last 3 months and is now having the episodic orthostatic hypotension and syncopal attack. She has been previously healthy except for hypothyroidism, which was due to autoimmune thyroiditis or Hashimoto's thyroiditis, and for that she is taking thyroid supplement, thyroxine. Her pulse rate is 120 per minute, so she has tachycardia, and her blood pressure is 88/50. She is thin and appears to be clinically ill, and physical examination also shows that she has vitiligo on in her trunk, the back. And so, given this situation, you got this following blood test. Her hemoglobin is 12.2 grams, low normal. WBC count is okay, 9,000. Neutrophil is a little bit low, 26%. However, lymphocyte and eosinophil seems to be high. Lymphocyte eosinophil is high. Monocyte is also high. Basophil is 4%. Platelet is normal. Serum sodium is 120 milliequivalent per liter. The reference is 135 to 145. Potassium is 5.8. Reference is 3.5 to 5. Chloride is 110. Bicarb is 18 milliequivalent per liter. Low normal, low range of the normal. Glucose is 65 milligram per dl. It's a little bit on the low side. BUN 19 milligram per dl is alright. Creatinine is 1 milligram per dl. Which of the following the best test in this patient evaluation of this patient? What will be the best test? Should it be a upper GI series? A serum cortisol with ACTase stimulation test, obtain a thyroid function test, do an upper GI endoscopy. Well, let's see what we have here. Lab-wise, what we have, hyponatremia and hyperkalemia. And the patient has lost a lot of weight, has orthostatic hypotension, low blood pressure, syncopal attack, and this is with low sodium and high potassium, suggest this patient has adrenal crisis or Addisonian disease, Addison's disease. This reason is autoimmune. You have seen right here in the history, previously healthy excepting hypothyroidism secondary to Hashimoto's thyroiditis. There is a saying, one autoimmune disease invites another one. And when somebody has hypothyroidism secondary to autoimmune thyroiditis or Hashimoto's thyroiditis, we always have to look for another one, and the second one, if at all comes, is going to be adrenal a problem. So this patient has Addison's disease. In the absence of hypothyroidism, one need to think about anorexia nervosa. Anorexia nervosa also present pretty much like that, but the electrolyte is going to be the clincher in making these diagnoses. Whenever somebody tell you that this patient has a low sodium, the next question you should ask, what is the potassium level? A serum sodium of 125 does not tell me anything unless we know that the patient has normal potassium. If the patient has normal potassium, it could be SIDS or psychogenic polydipsia, drink awful lot of fluid. However, high potassium and low sodium is something, please do remember, when you see an electrolyte with low sodium and high potassium, that's the adrenal gland. Okay, so it's very important. So now we are going to get a serum cortisol and ACTase stimulation test, and sometime it is in the early morning you can get the serum cortisol and ACTase level itself, and you may not have to do the test, but for there, here B is the right answer. The next patient is a 4 years old. This one was taken from your pediatric review. A 4-year-old boy is admitted to the hospital with new onset diabetes and rather severe diabetic ketoacidosis. His initial blood studies were as follows: sodium was 135, potassium 5, and glucose 900. Severe hyperglycemia. And after 8 hours of treatment, his blood studies were as follows. Blood glucose is 110 milligram. Well, that looks pretty good. Sodium is 133, a little bit on the low side now, and the potassium is 3 milliequivalent per liter. Over the last few hours, he was complained of headache, vomited, and become confused and agitated. So next step in this management should be administer mannitol 0.25 grams per kg IV, obtain a CT scan of the head, increase the rate of the IV fluid, push 1 ml per kg of 20% glucose solution by IV, add 40 milliequivalent of potassium chloride in IV fluid. Okay, now let's look at that what we have done. This patient already was admitted with a severe hyperglycemic state, and at that time sodium was 135. But if you correct it, this is pseudo-hyponatremia. If you correct it, there is a formula. The formula is roughly, if you take 100 out of the 900, that will be 8. 8 times 1.6, you add that with 135, so that will be in a hypernatremic range. And therefore, this patient has hyperglycemia, hypernatremia, but because of the fluid management and whatever was done has not been really proper, and the patient blood sugar has dropped significantly. The normal one should be about 100 milligram, and at the same time sodium has also dropped, so patient is also very young, and this complaint of headache, vomiting, and become confused and agitated is nothing but the suggestion of cerebral edema. And so therefore, when we manage the patient with DKA, we are very careful, making sure that the glucose is not dropping too fast and sodium level is not dropping that much. We want to keep it exactly within the normal range, and the neurological examination has to be done hourly, and that's why any patient with DKA is in pediatric ICU or any form of intensive care unit. So the first thing you do is the mannitol. Don't wait for a CT scan or MRI or all this stuff. The patient needs mannitol. And this has been again emphasized in my lecture of DKA management made easy. Okay, this is another patient, 5 years, 6-month-old African American female, brought to your clinic for the concern of PB care development, and that has been noted for the period of 6 months. Her weight is on 97th percentile and the height is on 60th percentile. She has no clitoromegaly but has developed adult type of body odor but no axillary hair. The pubic hair is tenar 2, mostly along the labial border, and there is no breast development. Of the following most important clinical screening study is A. Bone radiograph or bone age, B. Serum hydroxyprogesterone, C. Serum testosterone, D is pelvic and abdominal sonogram, and E is the MRI of the brain. Okay, so what is our concern here? Is it a precocious puberty or is it a late onset congenital adrenal hyperplasia, 11 or 21 hydroxylase deficiency? Or is it a condition what we call pretty benign condition? Pretty benign, I said, but it's not all that benign, is premature adrenarche. So, among the tests that has been proposed, if it is 17 hydroxy or 11 or any of precocious puberty or peripheral precocious puberty, the bone age will be advanced. And in premature adrenarche, the bone age is very slightly advanced to within a reference range. So bone age will be the first thing you should be doing. If this is advanced, significantly more than 2 standard deviation, then you should worry and do further test. But if the bone age is not advanced, then it is most likely premature adrenarche, because the distribution of the pubic hair is keeping with premature adrenarche along the labial border, and you do see the adult type of body odor, especially in the axillary area in premature adrenarche as well. And if any blood test need to be done, it is going to be dehydroepiandrosterone sulfate, DHEAS, because 90% of them come from adrenal gland. So many people call that's the puberty of the adrenal gland. So the answer is bone age. 12 years old, diagnosed with type 1 diabetes for about 4 years. Her diabetes control has been satisfactory, recently having frequent hypoglycemic episode. She has gained about 3 kg of weight in 3 months, and she is in early puberty. Physical examination shows fullness in front of her neck, which appears to be a thyromegaly or goiter. So most likely cause of thyroid enlargement would be, is it a pubertal thyroid gland enlargement, which some people believe that at puberty that thyroid gland tend to enlarge a little bit. Could it be Hashimoto's thyroiditis? Could it be iodine deficiency? Or is she developing Graves' disease? Or she has multinodular goiter associated with diabetes? Okay, now let's see. This patient has got a goiter, has gained 3 kg of weight. That tells you that patient most likely does not have Graves' disease, because there you lose weight. So that is not the issue. Iodine deficiency is extremely uncommon in this country, or even in the Western country, and most of the developing country now supplemented. Iodine is supplemented with the salt and many other food. So therefore iodine deficiency is very, very unlikely. And multinodular goiter, the E1, is extremely uncommon in pediatric age group. So the examination will be different. The multinodular goiter is very, very unlikely in pediatrics. So Hashimoto's thyroiditis is the most credible answer, or autoimmune thyroiditis. As you know, type 1 diabetes is an autoimmune disease. So, and what we see especially when you follow them in the endocrine clinic, we always make sure that we are examining the thyroid. And many clinics, once a year, they do the thyroid function test. I don't think that's a bad idea. Graves' disease can also occur because it's also an autoimmune disease with type 1 diabetes, but less than Hashimoto's thyroiditis. So number B is the correct answer. for this question. During health supervision visit, the 10 years old girl, you know that her height is at 97th percentile and the weight is 85th percentile. Her mother is 5 feet 5 inches tall and dad is 5'10". And her parent asked if she will be very tall when she is done with her growing. This question was also taken from the pediatric review. Okay. Of the following, the most important element of the physical examination that will help you to answer the questions there should be one answer, is arm span measurement, body mass index, upper and lower segment ratio, sexual maturity rating. Now let's look at this answer. Well, none of those A, B or C seems to be credible. Now sexual maturity rating is very important because if she is developing early, if she already has, say for example, significant breast development like close to stage 3 or 4, or already started her period early, then she does not have that much growth left. But she still is prepubertal or has got only 10 or 2 breast development, you will find that she has got plenty, and you will deduce that she has plenty of growth left. So sexual maturity rating is the one is going to give you the answer. As you know, in my precocious puberty lecture, I told you that once the patient has started her period or menarche, after that the growth rate is about 2 to 3 inches. So the sexual maturity rating will be the best answer. A 14-month-old brought to your clinic because he is very jittery. Mother felt he may have a seizure last night. During the physical examination, you find the baby has tetany that you have to elicit by a certain test. And lab done very quickly, which shows the serum calcium 4.5. This is total calcium, which is very low, and normal is 8.5 to 10.5, and serum phosphate is 8.6 milligram per dl, significantly elevated. The normal will be up to 5, maximum 5.6. Serum glucose is normal, electrolyte BUN and creatinine is also normal. Now these are the choice you have. Could it be a dietary calcium deficiency? Could it be a hypoparathyroidism? Is it hyperphosphatemia? Or it is vitamin D deficiency ricket or vitamin D resistant ricket? Well, ionized calcium is not here, but still, if this patient has got all other lab parameters is normal, the 4.5 total calcium is very low. So what we have found here is the patient has significantly, severely low calcium, but very high phosphate with normal kidney function. Please do remember this. When you see a patient who has a low calcium, high phosphate, low calcium and high phosphate, after the age of 1 year? There is only one answer. This is hypoparathyroidism. This is not your rickets or vitamin D deficiency, where they have low calcium but it never goes that low, and the phosphate also normal to low. So hypoparathyroidism is the answer. So anytime if you look at if the calcium is low, look for the phosphorus. If the phosphate is high, calcium is low, only one answer, and that is your hypoparathyroidism. Next question is: a 14-month-old boy brought to your clinic because he is very jittery. Okay. This question is already answered. And so now these are the quick, I call rapid fire question. The most common metabolic disorder in the newborn is phenylketonuria, urea cycle defect, glycogen storage disease, or trisonemia. Number 1, A is the phenylketonuria. That's the most common metabolic disease, is 1 in 15,000, and this first screening test in this country was developed for phenylketonuria. So mean is 1 in 15,000, but it could vary between 1 in 10 to 25,000. So it is phenylketonuria. The maximum growth usually occurs in girls: A, just before thelarchy; B, about a year before menarche; C, about a year after menarche; and D, about the time of appearance of pubic and axillary hair. Well, in my previous lectures, in peripheral precocious puberty and central precocious puberty, I made it clear, and normal pubertal development in girls, the significant height increment occurs just about a year before her first period. So it's about a year before menarche, not just before thelarchy, and it's about once the girl has started her period, after her first or second menstrual period, you expect about 2 to 3 inches height increment in future. So a girl has done almost all of her growth by the time she started her period. So it is a year before menarche. Which of the following statement is not true about constitutional delay of growth? Birth weight and length is likely are like other babies, average. Growth velocity declined between the age of 6 months to 2 years. The bone age is delayed, and the puberty occurs at due time. This is kind of easy answer. So answer is D. Puberty occurs at due time? No, because the bone age is delayed. The pubertal development corresponds with the bone maturation. And so since they are constitutional delay, they will have growth spurt. Their puberty is delayed and the growth spurt will be delayed. So therefore D is the answer, which is not true. Which of the following statement is not true about central diabetes insipidus? ADH is synthesized in posterior pituitary gland. B, ADH receptors are in distal nephron and collecting duct. C, it works by activating cyclical AMP. And D, is stimulated by hypovolemia and hypoosmolality. Which one should be the right answer? And all B, C and D is right answer. A is not the right answer. ADH is not secreted in the pituitary gland. It is secreted in supraoptic and paraventricular nucleus in hypothalamus. And my diabetes insipidus lecture, I made it clear, posterior pituitary is a storehouse. It just only store ADAs, and it is synthesized in hypothalamus by supraoptic and paraventricular nucleus. Normal growth rate of a child between the age of 6 to 10 years old should be a 3 to 4 centimeter per year, 4 to 5 to 6 centimeter per year, 6 to 8 centimeter per year, above 8 centimeter per year, or is the growth rate remains same from the age 1 to 10 years? Well, the right answer is B, 4.5 to 6 centimeter. Remember that if a child at that age or after the age of actually 4 or 5, the average growth rate or growth velocity is 5 centimeter per year. However, 4.5 to 6 centimeter is acceptable because those have familial short stature, they probably will grow at the rate of 6. So 4.5 is the familial short stature, so 4.5 to 6 is the right answer. And growth rate clearly not remains same between 1 to 10 years. And this is a good question. Always remember that just before puberty changes the growth velocity, and first 3 to 4 years the growth rate is not same. So between after the age of 5 to 10 or on the before the onset of the puberty is about 5 centimeter. So answer is B. And I don't want to push anymore because of the fact that mental fatigue, and you can only concentrate that much. And I will post many more of multiple choice question and small board review cases and with the explanation. And I hope that this has been of some help. And if you like this, not only with the lecture, I will also submit more of short case and the multiple case. And if you like, you can subscribe my channel, and that way anytime I submit something you will be notified. Okay, or you can, I have provided my YouTube channel, and also if you do not have that, you can just simply type pediatric endocrine lecture by Dr. Bhowmick, and that will also bring the whole supplement, whole the one that has been has been put so far in the YouTube, and there should be quite a few. Thank you very much.